I want to start out with a question. How many of you watching this talk feel lonely? Feel like you lack companionship? Feel left out or isolated from people? So research has told me that half of those watching right now feel lonely sometimes or nearly always. And that's just the general US adult population. 1 in 5 millennials feels like they have no friends. And 60% of US nursing home residents never have visitors. Loneliness is more prevalent than diagnoses like heart disease, depression, or dementia. Given those numbers, it's easy to see why many have said that loneliness has become the social epidemic of our decade. COVID-19 certainly exacerbated this troubling trend, but the roots of loneliness were already in place before social distancing and quarantine were part of our regular conversations. In 2020, US Surgeon General Dr. Vivek Murthy wrote a book about loneliness entitled Together, The Healing Power of Human Connection in a Sometimes Lonely World. In his book, Dr. Murthy argues that loneliness is affecting our health, our school, our work, and the sense of division in our society. During the last 2 years, COVID-19 has forced people all over the world into social isolation. Most of us had never before experienced that kind of disconnection. I think it led to a deeper universal understanding and empathy for loneliness. People started recognizing that social contact is a basic human need, like food and sleep. Not having regular social contact felt for some as bad as starvation or sleep deprivation. People all over the world got creative on how to connect during quarantine. How many of you remember the cell phone videos from Italy of people standing out on their balconies and singing with their neighbors? Or read stories about the kids writing cards and drawing pictures for elderly in nursing homes? Now, not everyone suffers from loneliness when socially isolated. And that's because loneliness is a subjective experience. Someone feels lonely when they don't have the relationships they would like to have. Some people perceive having just 1 or 2 relationships as plenty. Others need more relationships to feel well connected. This is also how loneliness and social isolation differ. You can spend the majority of your time completely alone and not feel lonely at all. Conversely, you can be happily married or in a crowded room and still feel lonely. Again, loneliness is a subjective experience. This issue, this epidemic of loneliness, isn't just a sad story to reflect on. Loneliness has real consequences on health and healthcare costs. There are plenty of research articles that show pretty stark numbers about how chronic loneliness can affect health. Those who are lonely have a 30% increased risk of stroke and heart disease, and a 40% higher risk for developing dementia. Loneliness leads to depression and suicidal thought. These conditions are some of the most life-altering and most costly of any diagnoses, and we know that loneliness puts people at higher risk for them. So this is affecting healthcare outcomes and costs in a couple ways. First, patients who are lonely tend to use the doctor's office or ER as a way to socially connect. So our medical system is being tied up with patients who are actually just feeling lonely and maybe don't need those costly clinic visits. Secondly, when chronic loneliness does result in clinical diagnoses, a patient's overall health declines and becomes more costly. Medicare spends almost $7 billion a year more on patients who are socially isolated. I've worked in healthcare and social work for almost 20 years. The research I've read about loneliness isn't really surprising to me. I've seen how serious loneliness is for the patients I've worked with over the years. I've seen it with homebound patients, those with medical issues and mental health conditions. I've seen loneliness in patients who may have had trauma or substance use issues, who may have pushed away family and friends, and then later in life find themselves feeling alone and lonely. There are people out there that go weeks, even months, without talking to anyone. Ask anyone who's worked in healthcare. It's not uncommon to leave an appointment with a patient and realize they probably got more out of the social interaction than the clinical intervention provided. And while this can help with developing a rapport, it does take away precious clinical time and service in an already stressed healthcare system. I can't tell you how many times patients, caregivers, and healthcare colleagues have asked me, isn't there a service where someone can just check in, just call and chat for a little bit? But this isn't offered in healthcare systems. Insurance only pays for healthcare services that are connected to a diagnosis, or if someone needs hands-on care due to a physical disability. Mental health services are the same. There has to be a diagnosis to connect to any billable clinical mental health treatment. But what about patients who don't meet those clinical needs, but are suffering from loneliness? Doesn't healthcare have an obligation to address that health problem, given all we know about its high health risk? So what if I told you that we have a way for healthcare providers to address loneliness with their patients? It's called social prescribing. It's a fancy term to describe a simple concept. Social prescribing uses that gold standard exchange between a doctor and a patient, the prescription, to link a patient with programs. The goal of social prescribing is to increase patients' social connectedness and community engagement, ultimately reducing loneliness and those associated health risks. So you may wonder what those programs look like. Well, one example is the Department of Veteran Affairs Compassionate Contact Corps program. This is a phone buddy program, matching trained VA volunteers with veterans who are feeling lonely. I was part of the team that developed this VA program just as COVID was spreading in the spring of 2020. It's been hugely successful, has been implemented in dozens of VA sites, and our data has proven it's been effective in decreasing veteran loneliness and improving their overall well-being. That program was actually created from another social prescription, the VA Volunteer In-Home Visitor Program. This one sends volunteers into veterans' homes, mostly homebound patients, to provide that same kind of friendly conversation and socialization. An added benefit of this social prescription program is it can also offer caregivers respite. Caregivers are actually at especially high risk of loneliness due to the isolating nature of the work they do every day. Social prescribing is already working in the UK. In 2018, they were the first country to appoint a Minister of Loneliness. Their National Health Service incorporated social prescribing into its primary care clinics. Patients there are now reporting lower levels of loneliness, improved well-being, and fewer non-medical primary care appointments. In 2021, Japan became the second country to appoint a Minister of Loneliness. These two countries are jointly leading the global community on knowledge to overcome the stigma of feeling lonely. The call to action on loneliness and social prescribing is rising in the US. In Dr. Murthy's book, he argues that we need more partnerships between healthcare system and community organizations that offer these kinds of grassroots programs. The New York Times featured social prescribing in their Future of Healthcare series. The article gave examples of how it's working and even cited the VA's Compassionate Contact Corps as an example of a successful social prescribing program in the US. Doctors across the country looking to provide a more holistic medical approach see social prescribing as a vital shift in medicine. The US is faced with the same loneliness epidemic as the UK, Japan, and so many other countries across the world. I think it's time for American healthcare to join in that global conversation. Let's tackle this issue of loneliness together. Thank you.